Hello everyone, welcome. This channel is for pharmacy students who want to learn pharmacotherapy in a fun and engaging way. Today we will discuss STEMI, a type of cardiovascular disease. Let's dive into STEMI pharmacotherapy with Shimpool. We have a 72-year-old male patient with a history of diabetes, hypertension and atrial fibrillation. Last night, after drinking alcohol, he experienced chest pain starting at 9 p.m. and came to the emergency room at 11 p.m. as the pain continued. 2 years ago, he was diagnosed with atrial fibrillation at another hospital and took medication for about a month. However, he stopped taking the medication due to loss of follow-up. He complains of chest pain. Tests showed significantly elevated cardiac enzymes, CKMB and troponin, and the ECG revealed ST elevation. He was diagnosed with STEMI and atrial fibrillation, and we plan to perform coronary angiography and percutaneous coronary intervention. Here's a quiz. What is the appropriate loading dose of antiplatelet medication to prevent blood clots during percutaneous coronary intervention? Let's first take a look at the ACS classification. Acute coronary syndrome, ACS, can be categorized into two types: non-ST segment elevation ACS and ST segment elevation myocardial infarction. Both are caused by the rupture of plaque within the coronary arteries. Let's quickly go over these three diagnoses. First, unstable angina. In this case, the patient experiences chest pain, but there's no actual heart muscle damage, meaning no myocardial infarction. Non-ST segment elevation, myocardial infarction or NSTE-ACS, coronary artery blockage has led to actual myocardial infarction, meaning heart muscle damage. However, there's no ST segment elevation on the ECG. ST segment elevation myocardial infarction, or STEMI, is the most serious of these heart attacks. If someone's having a STEMI, they will have severe chest pain, their heart enzyme levels will be very high, and you'll see a clear ST segment elevation. So we had this patient come in complaining of chest pain right under their breastbone. When we checked their cardiac enzymes, CKMB and troponin, they were definitely through the roof. And then the ECG showed clear ST elevation. That's how we knew it was a STEMI. In STEMI patients, the coronary artery linked to the heart attack is completely blocked by a clot. To minimize heart muscle damage, we need to quickly restore blood flow. That's why we perform a percutaneous coronary intervention or use clot-busting medications called thrombolytics. The goal is to restore blood flow as quickly as possible. When we perform PCI, we need to consider adjunctive antiplatelet therapy. Typically, we'll administer a combination of aspirin and a P2Y12 receptor inhibitor. As you can see from this table, the aspirin loading dose is typically 150 to 300 milligrams. As for the P2Y12 receptor inhibitor loading dose, it's 600 milligrams for clopidogrel, 60 milligrams for prasugrel, and 180 milligrams for ticagrelor. So, for the first quiz, we know aspirin should be between 150 and 300 milligrams. That narrows it down to options 3 and 4, both showing 300 milligrams. Clopidogrel requires 600 milligrams, and ticagrelor needs 180 milligrams. Therefore, the correct answer is option 4, 300 milligrams of aspirin and 180 milligrams of ticagrelor. Historically, clopidogrel 600 milligram of loading dose was standard. However, considering the potential increase in bleeding risks, the latest guidelines now recommend a range of 300 to 600 milligrams, tailored to individual patient characteristics. Today's tip: when treating STEMI, remember the loading and maintenance doses of antiplatelet medications during coronary intervention. For clopidogrel, it's 600 milligrams for loading and 75 milligrams for maintenance. Prasugrel is 60 milligrams for loading and 10 milligrams for maintenance. And ticagrelor is 180 milligrams for loading and 90 milligrams twice daily. We hope you've enjoyed this video. Our next video will be STEMI Part 2. Your support through subscriptions, likes and notifications is greatly appreciated. We look forward to seeing you again in our next video. See you later.